You come to the rostrum, please. Perhaps the plane was late. Well, shall we move on then? Yes. So the next paper is concerning single incision versus laparoscopic colectomy, a case match series, and will be presented by Diego Ramos-Valadez, and this is from nearby in Houston, Texas. Thank you very much. At least you've made it. You haven't so far to come.
Good morning. I'd like to thank the distinguished member for the opportunity of the podium. These are our disclosures. So single incision laparoscopic colectomy was first described by Butcher in 2008, who described a right hemicolectomy. More recently, there has been growing enthusiasm and experience for single port colon resection. Some of the reported and proposed advantages of this technique include improved cosmesis, avoidance of multiple trocar placements, reduced postoperative pain, and diminished risk of incisional hernias. The majority of the published data, as shown here, involves single incision right hemicolectomies. However, comparative analysis is limited in which single incision sigmoidolectomy is directly evaluated versus conventional laparoscopic surgery. So the aim of this study was to compare single incision laparoscopic sigmoid resection versus conventional laparoscopic sigmoid resection in regards to safety, feasibility, intraoperative outcomes, and postoperative outcomes. We utilized the following methodology. In a one-year period, we did and performed a total of 77 patients that had single incision laparoscopic colectomy. From those cases, we were able to match 20 single incision laparoscopic sigmoid resection to 20 conventional laparoscopic sigmoid resection based on four matching criteria, which was gender, age, pathology, and type of procedure. All the single incision cases were done with a single incision device. Most of the cases required the use of a gel point device, and some of the other cases required the use of a gel port device. All cases, single incision and conventional laparoscopic cases, were done with standard non-articulating laparoscopic instrumentation and with a 5 mm 30-degree laparoscopic camera using a right angle cord adapter. Demographic data, intraoperative parameters, and postoperative outcomes were assessed. In regards to matching criteria and other postoperative parameters, there were no difference between gender, age, pathology, procedure, ASA, and past surgical history. We did find a significant statistical difference in BMI, but the mean BMI between both cases was, they have a range of 25 and 30. In regards to intraoperative outcomes, there was a significant diminished difference in the single incision group. However, this did not interfere with the clinical management. There was not difference between the operative times in each group, and we have no conversions to open surgery. Only one case of single incision laparoscopic sigmoid resection required the multi-port approach, which we considered was converted to another minimally invasive technique. In regards to postoperative outcomes, the mean length of stay for the single incision laparoscopic sigmoid resection was 3.2 versus 3.8 to the conventional laparoscopic colectomies. But it was not significantly different. We didn't have any significant difference in complication rate, and there were no reparative interventions or readmissions in either group. In regards to malignancy, there were similar outcomes on both groups. In the single incision group, we have a mean lymph node extraction of 20.3, and the conventional group had a lymph node extraction of 18.3. These are limitations. It was a retrospective analysis, and the cases that were done a single incision laparoscopic sigmoid resection compared to the laparoscopic conventional sigmoid resections, they were done earlier than the other group. And it was a small cohort of patients. So in conclusion, when compared with standard laparoscopic colon resection, the single incision technique results in similar short-term benefits, a short hospital length of stay, and low complication rate. And this technique can be performed in those patients with prior abdominal surgery and does not result in increased operative times, estimated blood loss, or intraoperative complications, resulting in improved cosmesis and avoidance of multiple trocar placement. So this technique have a low conversion rate and can be salvaged with another minimal invasive technique as multi-port or hand-assisted technique. However, comparative analysis, including larger cohort of patients and randomized trials, may elicit additional benefits and limitations of this technique. Thank you.
This paper is now open for questions from the audience. In the interim, I'll ask you a question. How selective are you being in terms of choosing patients for a single incision approach? I think that's possibly indicated by the difference in body mass index in your two groups.
Right. In this study, we didn't have any selection criteria, but it is important to further evaluate some other parameters where we want to include the patients, but as I repeat that, we didn't have any criteria for including the patients.
So at this point, anyone whom you would consider, previously would have considered for a laparoscopic approach, you're now trying them as a single incision procedure?
Yeah, we were seeing that patients that had a BMI with in between 30 35, there were very challenging cases, so we're considering the BMI as a criteria.
Okay, so you are selecting them to some extent.
Right.
Okay.
I can perhaps, that's a very good question. Good presentation, Diego. I'm the senior author. But what happens, what we're doing now in our practice is that all comers we consider single incision. If the BMI is 35 and above, we've noticed that to be very challenging, especially in the pelvis. But below 30, basically we're doing them all single incision. The group that's difficult is between 30 and 35. And those are the ones that it's we start off single incision and we see where it goes. Greater than 35, we don't see the benefits outweighing the struggles of the procedure.
Could you be a bit more specific in terms of difficulty?
Well, difficulty when the BMI gets in the 30, mid-30, upper 30 range, the mesentery is so stubby and foreshortened and doesn't allow good retraction. It's fatty. You can't see the vessels very well. And with the coaxial alignment of the camera and the instruments, not having a third triangulating point of access, it becomes, you can do it, and we can do it, but you wonder, is this really going to benefit the patient with the extra struggle, time, and loss of tissue planes?
So when you talk about needing an extra instrument to manipulate the colon, have you tried devices that have more ports to them, or are you just adding an additional trocar?
That's why we use the gel point, because we stick in, sometimes we have as many as 5 trocars in there, 1 for the camera and 3. Of course, they start getting external and internal collisions when you add too many. But we started using some of the devices that only allowed 3, and we've switched to the ones like the gel point or gel port that allow many. And if you notice in this study, sometimes we use the hand assist device. We cover it with Tegaderm. And so when we go in, and if it's a big bulky tumor or bulky diverticular disease, many times we go straight from single incision to hand assisted. And we're finding that multi-port is having less and less of a role in our practice. It's kind of one or the other. We're almost skipping the multi-port option in a lot of our patients.
So just to be a little fanatical here about the single incision, don't you consider if you're sticking your hand in through a single incision device that's now converted?
Yeah, we do. We recognize that as a conversion to another minimally invasive technique. But it is we do consider that a conversion.
Good comeback. Thank you very much.
Okay.
Thank you.
The Does anyone else in the audience perform single incision colonic resection? It'd be interesting to see how that changes over the next 2 or 3 years.
I would now like to invite Dr. Alejandro Canelas to the podium to present emergency laparoscopic approach in patients with ulcerative